Welcome back, vlog. If you guys watched last week's vlog, then you know I'm on my cardiac block right now. And today we are doing a pulmonary thromboendarterectomy. Pulmonary thromboendarterectomies are big cases. It's like over an hour for me to set them up, so I'm here pretty early. I'll tell you more about them in a sec, but I need to get into the hospital and start getting set up. Alright, so I'm going to try to explain what a pulmonary thromboendarterectomy is while I'm setting up for it a little bit here. So you guys have heard of pulmonary embolisms, or blood clots in the lungs. Those are very dangerous, very big deals, and people can get them from having clots in their legs and them getting thrown to the lungs, or just really having atherosclerotic disease and then that forming, a clot breaking off that travels somewhere. Well, people can have essentially what's called chronic thromboembolic pulmonary hypertension. So essentially getting these blood clots that are so large that they actually take up a bunch of space in the pulmonary vasculature, essentially shaping through the pulmonary vascular tree. Now, as I'm sure you guys can imagine, that would cause some pretty significant issues with breathing. Essentially, what you're doing is you are ventilating the parts of your lungs that are not receiving blood flow, because that blood flow is being obstructed by these large pulmonary clots. So this disease has pretty significant morbidity and mortality. But some patients can be deemed as surgical candidates and actually have surgery to have these clots removed. And it's pretty involved. Essentially, the patient needs to go on complete circulatory bypass. So you're stopping the heart, you're stopping their lungs from breathing so that the surgery team can go in and take these clots out. So when you're on bypass, essentially the bypass machine is oxygenating for you. Your lungs are not being ventilated by us. Your heart is completely stopped. And so I'm sure you guys can imagine that the anesthesia setup is quite large for that. I'll talk more about it later, but I'm gonna finish setting up for now. This is the bypass machine for anyone that's curious. All right, guys, I'm done setting up for the PTE. Like I was saying, big setup, but my cardiac fellow let me get out to grab some brekkie. So we did a pre-op A-line, rolled back to the room. That way we can monitor their blood pressure, make sure they're hemodynamically stable on induction of anesthesia. Very important in these cases. Once they're asleep, breathing tube goes in, central line goes in the neck. We float a Swan catheter to be able to monitor pulmonary pressures. And then go down below, do another arterial line in the femoral artery. Antibiotics go in, meds go in. This entire time you're managing their hemodynamics, anesthesia's ready, and then the surgery team comes in and gets started. That whole thing takes like almost an hour. So that's like, again, a big setup. Anyway, I'm gonna finish eating and then head back to the OR. And we are done. Sorry, not a lot of vlogging. These cardiac cases are really involved, very busy. Long days. I'm honestly exhausted, so I'm gonna go home and then we'll talk more about this cardiac rotation and the kind of cases I've been up to later on in the vlog. All right, guys, so I am back from another long day at the hospital. It's always after these long days, especially now being on cardiac, that I feel like I get home and everything hurts. My back hurts, my head hurts. All the stuff that I've been like putting off seeing a doctor about just like catch up to me. Now here's the thing, even though I'm a doctor myself, I am very guilty of putting off my own doctor's visits. And it's not because I don't care about myself and my health, but it's because I have literally the exact same frustrations that you all do when it comes to seeing a doctor. Getting on the phone with the office is annoying. Navigating insurance is annoying. And trying to schedule around my schedule, which is a doctor schedule that's pretty much like double full-time hours, feels impossible most of the time. So I push it off, deal with it later, book appointments later. But that's why the sponsor for this vlog is once again ZocDoc. You've heard me talk about ZocDoc before, and I absolutely love the way that they increase access to healthcare for people. And for someone like me, it really makes sense. So I love sharing what they do with you guys. ZocDoc is a completely free website where you search, compare, and book doctors based on what matters to you: your insurance, location, and your schedule. You can read actual verified patient reviews, look through provider profiles, and choose based on your own preferences. So instead of just choosing a provider who has an opening, you're choosing the one that's best for you. You can see actual appointment availability in real time and book in just a few clicks. And a lot of the appointments are within 24 to 72 hours, and sometimes even on the same day, which is huge if right now you're deciding, you know, I should actually go see a doctor today. I recently got set up with my primary care doctor through ZocDoc, and it was so quick, so convenient. They're like 3 minutes down the street from my house. I really appreciate that I was able to book my appointment on my own time rather than having to do it during office hours, which again is impossible for a resident who's always working. In fact, just yesterday, I booked another appointment with a dermatologist because, as you guys can see, kind of breaking out a lot here, so it's time to go see a derm. ZocDoc has over 150,000 providers across more than 200 specialties. That includes primary care, dental, mental health, eye care, even urgent care. All in one place, completely free to use. So if you've been putting off making an appointment because you're tired, busy, overwhelmed, or just hate the process, because same, then I highly recommend you guys go check out ZocDoc. You guys can go to ZocDoc.com/Sean Anderson and check that appointment off of your to-do list. Again, even as a doctor, I force myself to make these appointments to take care of my health. If I can do it with my busy residency schedule, you guys can too. Go check them out, and thank you to ZocDoc for once again sponsoring the channel. All right, guys, just got done with another day in the cardiac OR. In fact, this is the end of my 3rd week on cardiac. I told you guys earlier in the vlog I would catch you guys up a little bit. So I started my cardiac rotation 3 weeks ago, and I was quite nervous about it, mostly because cardiac anesthesia is pretty intense, right? Like, you're dealing with some very sick patients, and if they're in the cardiac OR and they are having some sort of intervention done by a cardiothoracic surgeon, something's wrong. And a lot of what we manage in anesthesia is hemodynamics, right? Like blood pressure, heart rate, your heart dynamics, your lung dynamics, to make sure that the rest of the body stays okay, you know, for lack of other words, during surgery. In a normal OR, maybe on like a regular, I don't know, day in trauma, you might have just like a otherwise healthy person coming in for, I don't know, like a broken leg, and they're getting an ORIF and fixed up. And that's a problem. That's a surgical issue. But from the anesthesia side, you know, if their lungs are good, their heart's good, all that kind of stuff, we're pretty confident and sure that they'll make it through the surgery just fine. And that really is the case. Anesthesia is pretty safe these days. However, if you're in the main OR and your patient has some sort of comorbid lung or heart issues, that now adds another level to the anesthesia care plan that they're gonna need. These are things like coronary artery disease. You know, you've got plaques in the vessels that supply blood to the heart. You could have valve problems, so severe mitral stenosis, aortic stenosis. You could have regurgitation, so leaky valves. Or you might have issues with the lungs, things like pulmonary fibrosis, blood clots in the lungs, right? There's a lot of different things that can make handling someone's hemodynamics and respiratory dynamics under anesthesia more complicated. But when you go into a cardiac OR, you are guaranteed to be dealing with those complications. And so I was nervous about that. I was excited in the sense that by getting through this part of my training, I will feel more comfortable managing these types of patients for their other anesthesia. But if they're coming to the operating room because of a heart problem or because of a lung problem, that's pretty significant disease. That's like severe aortic stenosis or severe pulmonary hypertension because of large pulmonary embolism, thromboembolism burden. What does that look like for me? Well, of course, the pre-oping is pretty in-depth because you are reviewing not only their entire past medical history, but also all these other studies they've had done for, you know, whatever issue that they're having. So if they're having a CABG, you're looking at, you know, their heart catheterization that they have, which vessels are occluded, what has those occlusions caused in terms of complications with the heart. For example, do they have any issues with the conduction system of the heart now, like the AV node? So maybe now they have like a heart block or some sort of like bradycardia. Do they have heart failure? Right, that's a big one. Is the heart even pumping blood as strong as it needs to? If it's not, that's pretty significant, because when we put someone under anesthesia, we drop your blood pressure, we drop your cardiac output. That's a big deal. If your heart's already not doing well, we don't want to make it worse. So there's a lot of pre-oping involved. You really want to know what's going on with these cases going in. Now, you guys know that my days have been quite early in anesthesia residency, but they've only gone earlier because these cardiac cases tend to be long and involved. We actually tend to start about an hour earlier than most of the other general operating rooms. And because the setup for that is even bigger, I get here much earlier. So I pretty much have to get here at least an hour and a half before we start cases. Where normally I can get here like maybe an hour or so before. So I've been getting up at like 4:30 every day. So that's been tough. That's actually been one of the tougher parts. So the flow is essentially I get to the hospital. The first thing I do is I actually do a wet scrub, because I will be doing some sterile procedures like central line, arterial line. And so I actually do a wet pre-scrub when I get there. Then I go to my operating room, sign into the EMR, order some things for the patient, make sure that nothing new happened or cases didn't get moved around. Then I actually immediately go and start drawing up all my medications, all my push drugs, things like etomidate, propofol, rocuronium, lidocaine for both for the radial arterial line that we do, and then also for the IV, heparin, Amicar, emergency drugs like epinephrine, vasopressin, phenylephrine, ephedrine, which we don't really use, but you always have it. You guys get the idea. And then we hang up our drips. These are things like your, normal saline that runs through, and dopamine, phenylephrine, nitro or clevidipine, propofol, insulin, all that stuff that you will need on an infusion. Then I do our standard setup for an operating room, like, your mom said, machine, oxygen monitor, suction, airway stuff, like your endotracheal tube, IV things, and then I confirm all my drugs are ready. And then I basically go and I talk to the patient in pre-op, and this is for things like, CABGs or PTEs or aortic valves. I go and talk to them in pre-op, but then I also do the arterial line, the pre-induction awake arterial line. That way we have an invasive blood pressure monitor while we are inducing them, because we need to know exactly what's happening while we are giving them medications to go off to sleep, because again, they have very sensitive hemodynamics. So that's a very important part of it. Give them some medicine to numb it up. It's a sterile procedure to place the line. And then once the operating room is ready, I roll them back. We get set up, hooking a bunch of monitors up. We go off to sleep per usual. Once we're off to sleep, breathing tube is in. I go scrub in for a central line, place a central line. If we need to measure pulmonary artery pressures, I float a swan. Get all that set up, get all of our drips and infusions and stuff in, antibiotics in. Sometimes we have to put a femoral arterial line as well, maybe a larger IV. You guys get it, big setup. The anesthesia setup part takes like an hour or so before the cardiothoracic team even has to come in. It's honestly pretty cool. A lot of the cases I've been seeing are things like CABGs, that's a big one, PTEs, which my program actually does more pulmonary thromboendarterectomies than any institution in the world, which is a pretty big flex. And honestly, one of the reasons I did choose to come to my program is, as tired as all this is, as overwhelmed as I feel, as anxious as I feel, as stressed as I am, one of the reasons I chose to come and do the training where I'm doing my training is because I wanted to make sure that when I left residency, I saw a wide breadth of cases and felt like I could manage things. And so what I'm doing right now is essentially why I chose to come to this program. So I have to remind myself of that. But yeah, I'll keep updating you guys as this rotation goes on. This is going to be 8 weeks total, so 2 blocks total. So I'm going to be in the cardiac OR until the end of July. And so that's a long time. So if you guys have any questions for me or things I can clarify, let me know in the comment section, and I'll talk more about it in the next vlog and the next vlog and whatever you guys want. These vlogs are for you just as much as they are for me. Anyway, that's it for now. Shout out again to ZocDoc for sponsoring this video. Make sure to go check them out. Thank you guys so much for watching, and I will see you guys in the next one. Bye.